When we look at the venous drainage in the abdomen, we take note of the fact that there are two separate venous systems in the abdomen. One venous system is represented here on this diagram, which is the inferior vena cava and its tributaries, which include, of course, the common iliac veins, the lumbar veins, the renal veins, adrenal veins, phrenic veins. So that's the inferior vena cava and its branches. The other venous system in the abdomen is the portal venous system, or the hepatic portal venous system, which includes the portal vein and its branches. So we want to ask the question of how do we know which organs drain into the portal system and which organs drain into the caval system? And the answer to that is that it's based on the embryology of the organs in the abdomen. Now, let me address something that's not precisely true, because you frequently will hear this, but it's not precisely true. Often you'll hear it said that the GI tract drains to the portal system and that the non-GI tract organs drain to the caval system. And as a generalization, that might be okay, but it certainly is not accurate in an absolute sense. Take note that we're talking about the embryonic status of the organ, not the adult status of the organ. So the organs that in the adult are secondarily retroperitoneal, that means that those organs were originally peritoneal. So therefore, those organs will drain into the portal system, whereas those organs that are primarily retroperitoneal are the organs that drain into the caval system. And if we look at the list of organs that we referred to previously, we again have the organs that are peritoneal in the adult. They've always been peritoneal, so they are draining into the portal. These organs that are secondarily retroperitoneal embryonically were peritoneal, so they also drain into the portal. And it's these organs that are the primary retroperitoneal organs. They're the organs that drain into the cava. So to come back to the point I made about it not separating out between GI tract and non-GI tract, let me point out to you, for example, that the spleen, seen here, is a peritoneal organ, but it certainly is not GI tract, but because it's peritoneal, it drains into the portal. And on the other hand, the lower rectum and the anal canal is certainly GI tract, but because it's primarily retroperitoneal, it drains into the cava. And that's why that generalization is not absolutely true. Well, what happens to the blood that drains into the portal vein, and what happens to the blood that drains into the cava? So if we look at this slide, we can see that the blood that's draining into the inferior vena cava will, of course, drain directly to the heart, since the inferior vena cava empties into the right atrium. The blood that drains into the portal vein, in order for that blood to get back to the heart, it has to go through the liver, through the sinusoids of the liver, then exit the liver, enter the hepatic veins. Then those hepatic veins get into the inferior vena cava to get to the heart. So that means that all of the portal venous return has to pass through the liver in order to get back to the heart, which sets up the problem for us that if there is a disease process that interferes with flow through the liver or through the portal system, that's going to interfere with the ability of blood to get back to the heart. So, for example, a tumor that might be compressing the portal vein, or, for example, tumors within the liver, or, for example, for fibrotic or cirrhotic liver disease, is going to interfere with blood flow through the sinusoids of the liver. Any of those disease processes will interfere with portal venous return. So that means that the body needs to find alternative pathways for the blood to get back to the heart if it's having difficulty getting back through the liver. So we need to talk about what those pathways are. Now, on this diagram, let's first take a look at the portal vein itself and its tributaries. So here's the portal vein. The portal vein is formed by the union of the superior mesenteric vein with the splenic vein. So the superior mesenteric vein and the splenic vein come together to form the portal vein. That happens right behind the neck of the pancreas. Remember that the splenic vein is running along the tail and body of the pancreas, and then as it crosses behind the neck of the pancreas, it gets joined by the superior mesenteric vein, and that creates the portal vein. The inferior mesenteric vein drains to the splenic vein, so blood from the inferior mesenteric to get back to the liver has to first go to the splenic, then to the portal to get to the liver. Let's follow the inferior mesenteric vein down to its end. Now, of course, along the way, it's giving off branches that are comparable to the arterial branches from the inferior mesenteric artery. So there'll be branches to the descending colon, the sigmoid colon, and so forth. But the final branch of the inferior mesenteric vein, just like the artery, the final branch is now called the superior rectal vein. And that superior rectal vein is draining the upper part of the rectum. Now, if you recall, the upper part of the rectum is secondarily retroperitoneal. In other words, it was peritoneal in the embryo originally, and that's why it is draining into the portal system. In contrast, the lower rectum and the anal canal is primarily retroperitoneal, and therefore it's going to be draining to the cava. And what we see schematized on this diagram are branches coming from the lower rectum and the anal canal, listed as inferior rectal veins. There are actually inferior and middle rectal veins. But the important point is that those veins ultimately drain back into the iliac venous system, which then drains back into the vena cava. So that means that in the region of the rectum, we have venous drainage to the portal system, and we have venous drainage to the caval system. And so we have the opportunity for a venous anastomosis between the portal and the caval system by way of those venous branches. And indeed that happens. Within the wall of the rectum, these superior rectal veins and inferior and middle rectal veins anastomose with one another, providing the opportunity for blood to be shunted from the portal system into the caval system. But recognize that in order for that kind of an anastomosis to work, we have to have the ability to reverse the direction of blood flow in the portal venous system. Anastomoses, whether they be arterial or venous, can only work if blood flow can reverse direction. In order for blood flow to reverse direction, you cannot have valves. Now, arteries don't have valves, so anastomoses work very nicely in arteries. Veins, well, some veins do have valves and some veins don't have valves. But as it turns out, the portal venous system, the portal vein and all of its tributaries do not have valves. The caval system those veins do have valves. So since the portal system does not have valves, we have the ability to reverse the direction of blood flow. And it means that the direction of blood flow will be determined simply by a pressure gradient, just as is the case in arteries. So the normal pressure gradient in the portal system is toward the liver. The normal direction of blood flow is, of course, toward the liver. But if you have an obstruction to flow within the liver, that obstruction will increase pressure in the portal system, called portal hypertension, and that increase of pressure will change the direction of the pressure gradient. So the pressure gradient will now be away from the liver, so blood can flow from the portal vein, out the splenic vein, down the inferior mesenteric vein, into the superior rectal vein, into the wall of the rectum, across those venous anastomoses, and then into the inferior and middle rectal veins, and then back to the portal system. Once we're back in the inferior rectal and iliac veins, now they do have valves, but we are traveling in the direction that the valves permit, so that's fine. So it's the absence of valves in the portal system that allows the reversal of flow. So here in the wall of the rectum, we have a portocaval anastomosis. Now, these veins that are anastomosing in the wall of the rectum, normally the only blood flow that they are carrying, in other words, the blood flow that they are built to carry normally, is simply the venous drainage from the rectum. So it's not that much blood flow. When we're using them as a portocaval shunt or a portocaval anastomosis, that means that those veins are now being called upon to take a huge increase of volume. All of this portal venous blood that is shunting across is traveling through these veins. So those veins are going to increase in size, increase in diameter, to accommodate this increased blood flow. Now, for almost the entire gut tube, the large veins that drain the gut tube are found toward the outer wall of the gut tube, toward the serosal surface of the gut tube. But there are two exceptions to that. One of the two exceptions is in the rectum, where the large veins are not toward the outer surface, the serosal surface, but rather toward the luminal surface. So these large veins are in the submucosa. And those are the veins that will dilate to accommodate this portocaval shunting. And those dilated veins in the submucosa will therefore bulge the overlying mucosa into the lumen of the rectum or anal canal, and that's what we will call hemorrhoids. So these varicosities of these rectal veins are hemorrhoids, and so one of the causes, certainly not the primary cause, but one of the causes, one of the differentials relating to hemorrhoids would be portal hypertension because of this portocaval shunting. Now, another clinically very important location for a similar kind of portocaval shunting is at the other end of the GI tract in the abdomen, in the esophagus. So when we look at the esophagus, we see a very similar pattern. The lower esophagus, the part of the esophagus below the diaphragm, in other words, the abdominal esophagus, is draining by way of esophageal veins that drain into gastric veins, which are branches of the portal vein. Because this is, of course, a peritoneal organ, the stomach and lower esophagus peritoneal, so they drain to the portal vein by way of the gastric veins. The thoracic portion of the esophagus, the part above the diaphragm, drains by way of esophageal veins that will drain into the azygos vein, and then which is the vein that drains the body wall of the thorax, and then the azygos vein will drain into the superior vena cava. So that means, again, in the wall of the esophagus, we have the opportunity for a portocaval anastomosis, with the portal contribution coming from the left gastric veins, giving these esophageal veins, the caval contribution, in this case superior caval, being these esophageal veins that go to the azygos and then to the SVC. So we have the same story with an increased portal pressure, portal hypertension, reversal of flow. That flow will take the blood from the portal system into the esophageal wall, across those anastomoses, then to the azygos and to the SVC. Same story. Those veins normally are carrying only venous drainage from the organ itself. They're now going to dilate because of this increase of volume. And those dilated veins, again, are in the submucosa. We said that there are two exceptions to the location of the large veins of the gut tube. We said the rectum was one, the esophagus is the other. So these dilated veins are in the submucosa. They bulge the overlying mucosa into the lumen, and we call that esophageal varices. So esophageal varices are certainly one of the common findings in portal hypertension. A third clinically important location for a shunt is by way of a vein that functionally is not all that important, but because of where it goes to, it presents a clinically important finding. Running along the ligamentum teres, which is what in the embryo used to be the umbilical vein, but no longer is a vein. But on its surface, there are very small veins that run along the ligamentum teres, and they are called the paraumbilical veins. The paraumbilical veins are direct branches of the portal system, and they, of course, will then simply follow along the path of the ligamentum teres, which means it takes it right to the umbilicus. That's where the ligamentum teres will lead you to, since it was the umbilical vein. So it'll get to the body wall in the region of the umbilicus. Then in the body wall, in the anterior body wall, there are going to be superficial veins in the superficial fascia called superficial epigastric veins. And superficial epigastric veins will either drain downward toward the iliac system of veins or upward toward the subclavian veins and then to the SVC. And so again, we have the opportunity for porto-caval anastomoses in the body wall in the region of the umbilicus. And these veins, again, will dilate because they are in the submucosa. They are visible through the skin when they dilate, and that results in this pattern of radiating veins from the region of the umbilicus, which has been given the name caput medusa because of its fanciful resemblance to the snakes of Medusa's head. So those are the important locations for porto-caval anastomoses. In the region of the umbilicus, paraumbilical veins anastomosing with superficial epigastric veins, giving us caput medusa. In the region of the rectum, superior rectal veins from the portal system, inferior and middle rectal veins from the caval system, giving us hemorrhoids. And in the region of the esophagus, the esophageal veins from the portal system with the thoracic esophageal veins of the azygous system, giving us esophageal varices.